Hey everyone, welcome to our Restrictive Lung Dysfunction lecture. This one should be pretty quick. It's only about 14 slides. So this is going to be coupled with the next lecture, which is about obstructive lung pathologies. So I just want to quickly just talk about the etiology of restrictive disorders versus obstructive. So to put it in the simplest possible terms, you can think of restrictive as an inability to get enough air in due to something that's reducing lung expansion. And there can be a number of different causes, but you can think of it as an inability to get enough air in, versus obstructive often is characterized by an inability to get air out. And so that will manifest in multiple different ways and different signs and symptoms, but generally speaking, you can think of those as being the best differentiator between the two disorders, restrictive versus obstructive lung pathologies. This lecture is about restrictive. With restrictive disorders, you have an abnormal reduction in ventilation. You're not getting enough air in and out of the lungs over a period of time. And this is due to a restriction in the expansion ability of the chest wall or of the lungs. And that leads to a decreased lung volume and decreased ventilation. A couple common causes are pulmonary fibrosis, as well as autoimmune disorders like rheumatoid arthritis, which can lead to scarring and damage to the alveoli, as well as several other disorders that we'll talk about. One thing that is unique to restrictive disorders is that the FEV1/FVC ratio remains about the same. And I need to explain this quickly. FEV1 is the amount of air you can forcibly exhale in 1 second versus the amount of air you can forcibly exhale, period. So it's a ratio. The higher this ratio, it means you can get air out quickly. The lower this ratio, meaning if this number goes down quite a bit below this number, then what that means is it takes you a longer amount of time to get air out. That's characteristic of obstructive disorders. Restrictive disorders, this little sign here means approximate. It's approximately the same ratio as before diagnosis. So we're going to just list some common restrictive diseases. First, we have idiopathic pulmonary fibrosis. Lung cancer, if you imagine a large tumor taking up space, that's going to limit the amount of air we can get in. Musculoskeletal causes, these could be adhesions, contractures, etc., that disallow chest wall expansion. You can have neuromuscular causes, pulmonary edema, sarcoidosis, pneumonia, connective tissue issues, traumatic causes, obesity, diabetes, etc. So we'll talk about most of those in this chapter. And then next chapter, we'll talk about some of these obstructive disorders. So this is a really interesting graph that shows us just sort of the general lung volumes associated with normal, restrictive, and obstructive states. Now, back to what we were saying on the first slide, notice obstructive disorders have increased volumes, which is interesting. And notice the ratio between the residual volume and vital capacity changes. The residual volume gets quite a bit bigger when compared to normal. That means there's a lot of air trapped inside the lungs that we can't get out. That's characteristic of obstructive disorders. With restrictive disorders, the ratio remains about the same, but the total volumes all decrease pretty evenly. Because for whatever reason, whether that's a tumor or decreased chest wall compliance, for some reason we can't get in as much air. And so a part of that pathogenesis is, like we mentioned, decreased compliance of the lungs. The chest wall or the lungs lose an ability to expand and inflate. Lung volume ratios stay the same, but they all decrease. And breathing effort increases. It becomes labored. Some classic signs and symptoms are rapid breathing, hypoxemia, decreased breath sounds, decreased lung volumes. Then we have DLCO, This stands for decreased or the diffusion capacity of the lungs for carbon monoxide. Diffusion capacity for the lungs for carbon monoxide. This is a really useful clinical lab test to assess diffusion ability of your lungs. This would be really useful in determining if, the issue is pleural effusion or pulmonary edema, a disorder that would decrease diffusion. This could help rule this in or out. Another common sign is cor pulmonale. This is a type of right-sided heart failure characterized by pulmonary hypertension and expansion of the right ventricle. Some common symptoms include shortness of breath, a dry cough, and an emaciated appearance. Now we're going to start going through the different disorders. So this is a disorder in infants. It's rare. 1% of infants affected worldwide, so not insignificant at 1%. And it's caused by an insufficient lung maturation linked directly to gestational age. So when you think of a premature birth, this is one of the things you're concerned about. A common treatment is CPAP and PEEP, which stands for continuous positive airway pressure and positive end expiratory pressure. If you are looking at these things online, they're often reported as the same thing. They are similar. They're both air being forcibly pushed into your lungs, but CPAP is continuous, whereas PEEP happens at specific times at the end of expiration. Surfactant replacement is another very efficacious treatment for respiratory distress syndrome, as well as corticosteroids pre-delivery. While the baby is still in the womb, you can give the mother corticosteroids to speed up lung maturation. This is a very unfortunate disorder. It's called idiopathic pulmonary fibrosis. Idiopathic meaning the cause is unknown. Typically, when the cause is unknown, it has something to do with gene-environment interaction or has some type of autoimmune mechanism. It is chronic, progressive, untreated. It's irreversible. You can't reverse the disease course. It is treatable technically, but that treatment won't reverse the disease progression, and it is lethal. Basically, this is, like most idiopathic disorders, a disease where someone has to have the wrong gene at the wrong time. A specific gene in a specific environment can trigger this disease. We don't know specifically what that environment or gene is. We just know that it seems to be a gene-environment interaction. It's treated with anti-inflammatories like corticosteroids, antifibrotics, oxygen, pulmonary rehab, and ultimately lung transplant. Pneumonia is a very common respiratory disorder with many different types and presentations, which you can find on page 141 and 143. Typically, it is caused by an infectious agent. You can have bacterial pneumonia, viral pneumonia, fungi and mycoplasms can also cause pneumonia. So any sort of infection of the lungs that causes exudate and inflammation is going to lead to restriction. It's going to lead to decreased lung volume and airway restriction. Pleural effusion is when you quite literally get fluid accumulating in the pleural space. This is different from pulmonary edema. Pulmonary edema is when the fluid is in the lung itself. If you remember what the word pleura means, it means the lung lining or lining of the thoracic cavity and covering of the lung. There's a fluid-filled space in between that normally is very thin, but with pleural effusion, it can fill with water. And as you can see, lung capacity and lung volumes are decreased significantly. So this is a type of restrictive disorder. There are 60 different causes. As you probably guessed, heart failure would be the most common, especially left-sided heart failure. This can happen with pneumonia as well because it brings extra circulation and fluid to the lungs to fight infection, as well as a tumor. A malignant neoplasm can cause this. You have elevated hydrostatic pressure in the capillaries, which equals increased fluid leakage into the pleural cavity. Treatment involves removing fluid and then addressing the underlying cause so it doesn't return. Atelectasis is a fancy name for any sort of lung collapse. It can be used to describe, it's a result of many other pathological disorders. Basically what happens is the parenchyma collapse. This is the portion of the lung that exchanges gas, where diffusion occurs. That's the parenchyma. It collapses, and then lung volumes decrease. It's common in bedridden patients who don't typically have their lungs inflated very much due to a lack of activity. So it's very common in bedridden patients. And fortunately, it responds well to interventions we can provide, like deep breathing exercises and incentive spirometry. ARDS is unfortunately a very dangerous disorder. It's a widespread inflammatory syndrome. With inflammation comes fluid and exudate and proliferation and often fibrosis. And fibrosis is scarring and connective tissue formation that destroys the functional ability of your lungs. One treatment is to do what's called lung protective ventilation, which is the minimal tidal volume that meets the ventilatory needs of the patient. So you have the patient do as small of breaths as possible to meet the needs of the patient, as well as applying PEEP or positive end expiratory pressure, prone positioning. Unfortunately, mortality is quite high, even with treatment, 50 to 70%. Pulmonary edema at first might sound like pleural effusion. It's fluid in the lungs, but remember, pleural effusion, that was fluid accumulating outside of the lung in the pleural space. This is fluid in the lung. Often, like pleural effusion, there's a cardiovascular cause, such as left-sided heart failure, increased pulmonary pressure, and treatment is aimed at decreasing cardiac preload because you want to decrease how much fluid is forced out of the right ventricle into the lungs, into pulmonary circulation with each beat. An incredibly common disorder, unfortunately, you guys have heard you talking about it in medical screening, is often a symptom of a DVT or a result of a DVT when a peripheral clot dislodges, moves up most often the inferior vena cava, into the right atrium, into the right ventricle, into the lungs. This is actually the most common acute pulmonary disorder, and it affects 300 to 600,000 Americans per year. So this is very common, and treatment begins with DVT prevention, which you guys have learned a bit about. Exercise plays a big role in that, physical activity, as well as medication regimen and diet and other things. One thing we can do in the hospital, especially in terms of activity, especially after a surgery, especially a lower extremity surgery like a knee replacement, is to perform ankle pumps, ambulation as quickly as possible, day of surgery ideally. Apply compression stockings, potentially pneumatic compression, and then, most likely they'll be on an anticoagulant. And that's it. This was a very short chapter. There's a lot of lectures this week, so hopefully that's welcome. The next lecture will cover obstructive disorders. Thank you.